Hey everyone, I'd like to extend a very warm welcome to everyone in the room, as well as everyone around the world who's watching this online, whether you're streaming or watching this live on YouTube. Thank you for coming to this Best of Bristol lecture given by Dr. Rachel Cowie from the School of Oral and Dental Sciences. Bob Lectures was started by a Bristol alumnus and is driven by a very enthusiastic student committee. However, it's important to say that our work would not be possible without the vital support of Professor Alvin Birdie, Bristol's Academic Director of Undergraduate Studies, as well as the funding he secured as part of the Bristol Institute for Learning and Teaching. We would also like to thank the Bristol SU and all members of the university staff who have worked with us to make this series such a success. Each of our speakers this year has been chosen from over 1,600 nominations, so I believe Dr. Cowie deserves a lot of credit for being one of the first representatives from the relatively tiny faculty of Oral and Dental Sciences. She is both a doctor and a dentist and juggles her teaching alongside seeing her patients, which is very commendable indeed. We received so many nice comments about her. Unfortunately, I can't list them all, but some of them were, she is brilliant, she's always willing to help and is very, very enthusiastic. And her passion for teaching and learning is contagious. Not very often I say that someone is a true role model, but her breadth of knowledge and manner on clinic with patients is truly inspiring. And so without further ado, I present Dr. Rachel Cowie.
Hi everyone, thank you very much for coming tonight. I know a lot of you already, but for those that don't know me, let me introduce myself. So my name's Rachel, I'm a newly appointed consultant working in oral medicine in the dental hospital and in the BRI. And I started my career in dentistry, then moved into medicine and decided to specialize in this little niche area which deals with medicine of the mouth. And it's an honor to lecture in such a nice venue tonight and as part of such a fantastic series of lectures as Best of Bristol. So thank you to the team for arranging it so well and also for just creating so many learning opportunities about subjects that I'd never have otherwise thought about. And also, it's nice to see such a healthy morbid curiosity. I thought the subject of obscure oral pathology would be enough to put a lot of you off, but there's still quite an appetite, I see, which is good. So welcome and thank you, and we'll make a start. So dentistry gets a really bad rap. It's not what we'd call a popular profession, outranking debt collectors, traffic wardens, politicians in online popularity surveys. This is Saint Apollonia, who's the patron saint of dentistry. Not named so for her dedicated and caring work in the profession, rather the fact that she was martyred in 249 AD, and her preceding torture involved the violent extraction of all her teeth, which is depicted in this lovely picture here. And history books and art galleries are littered with horrible scenes of dental treatment and dental torture. Sometimes it's really difficult to tell the difference between the two. And this reasonably famous bit of art on the right here, if you can see, is an ivory cutting of a tooth done by a French artist in the 1780s. And it opens up to see a tooth worm devouring a human. And on the right there, its toothache being depicted as equal to the tortures of hell. And I don't know whether you can read that because the projector's a little bit off here. But now, even now, the media loves to play on the villainy of dentistry. So a dentist drops an inch-long spike down a patient's throat. House of Horrors dentist, millionaire dentist who slaughtered the lion and then drove his £120,000 Porsche to a cocktail bar. So poor Cecil, I don't know whether you can read this, but I couldn't pass by the opportunity to share this nice little bit of CNN footage, journalism with you. So thank you for clarifying that, CNN. And the movies do love a good villainous dentist as well. And so I just thought, I am a fan of the movies, so I thought I'd just remind you of some of our, I don't know whether you can see this, I can't see it very well from here, but there's the dentist himself. We have Is It Safe, our Nazi dentist from Marathon Man. My own personal favourite, Steve Martin at his sadistic best in Little Shop of Horrors. And even poor little Lisa can't escape the tortures of the dental chair. But what I like to do is just take a minute to convince you that there's a little bit more to dentistry than meets the eye. And so they say that the eyes are the gateway or the window to the soul. And perhaps a little bit less romantically, the mouth is a gateway to the body. And the mouth is often the initial or sometimes the only site of a disease that can affect the whole body. But first of all, I'd just like to take you back a little bit and talk about how dentistry has thankfully evolved over the years. So this is a guy called Hezire, who is an Egyptian high official back in the early 3rd dynasty. That was around 2600 BC. And he was named as the great one of the ivory cutters. And you can see here he's depicted in this wooden carving with all of his tools. And he's the first person on record, really, to have practiced dentistry as a profession. And traditionally, the modification of teeth was done for ceremonial reasons. So here we've got some teeth that have been modified, and this is the Mayan population who blackened their teeth and also inserted fine gemstones into their teeth that they drilled cavities into with a hand-spun drill. South American tribes commonly filed their incisor teeth into points, sometimes to enhance natural beauty, other times to make them look more ferocious. There's a Brazilian tribe that did it to imitate the dreaded piranha fish. And still to this day, there's some people who are doing this, and this is an indigenous Vietnamese population that do it to make themselves look more dog-like. And it was a passage, a ceremonial passage from boyhood into manhood. So, dentistry used to be practiced by shamans and witch doctors who were believed to be able to disarm evil spirits and the demons of toothache. And there's been various practices over the years. So the Egyptians used to drill holes into the mandible and the maxilla to relieve the pains of toothache. And this is actually this is from an Egyptian burial ground. And you can see there's evidence of early restorative techniques here. 2 extracted teeth have been reimplanted by looks like an early bridging method. And it's difficult to know whether this was done while the person was still alive or whether it was done post-mortem. The Egyptians firmly believed that when a person died, the body had to be kept intact to house the soul in the afterworld. So it could have been done post-mortem for that reason. And there have been various treatments over the years as well. So sour vinegars for gum disease, hot poultices, laxatives, bits of spleen that are cut up and chewed and then spat out for toothache. And with the Greeks and the Romans came a little bit more science, the development of the early medical school, and some early tools that begin to bear resemblance to what we use today. And this is a Greek extraction forceps called the odontogra, which looks similar-ish to what we use today. And these are some of my favorites over the years. So this is a tongue extractor. So you'd pop a bit of a tongue that you didn't want to see into that bit and give it a yank and pull the tongue off. Sounds nice. This one is an obtunda, or an injection syringe, which would have injected anesthetic, usually cocaine, at the time that it was around. And to me, it didn't look like something, it looked like something that could have been in some horror country and western movie. And this gentle little thing called the dental screw forceps, and the screw went into the root to keep it in place when you were taking the tooth out. And the idea that disease initially presents in the mouth is not a new one. Galen was a Roman physician who believed in particular that diseases of the brain and the head and the neck would drain, he called them excrement, would drain into the mouth and present there. And he did make reference to disease at other sites as well, presenting in the mouth. And various texts through the years have made reference to dental signs preceding or predicting disease at other sites. So traditional Chinese medicine, in particular this thing called tongue diagnosis or tongue observation, is something that looks at the shape of a tongue, the fur, which is the coating, and the body and the movements of a tongue. and ascribes abnormalities of those things to specific diseases. And in traditional Chinese medicine, internal organs are inseparably linked to areas of the tongue by meridians and channels. So if, for example, the back bit of the tongue, I can barely read that, if the back bit of the tongue was problematic, that would link to the large and small intestine. And there are still medical experts today who believe that you can tell a lot just by looking at a tongue. So how much can you actually tell by looking in someone's mouth? Well, the first thing I want to ask is how many of you, probably quite a lot of you actually, because you're dentists, have looked inside your mouth, and how many know it really well? What's normal for the bottom of a tongue? Have you ever had a torch and had a good kind of poke around in the nooks and crannies? We don't do it, and it's funny because we use it for eating and speaking and talking and everything that we do in our lives, but we don't really know what it looks like. And a lot of people that come in to see us are people that have had a good rummage and suddenly found a bony bit or a red bit or a white bit, and they get freaked out and they think, is this a normal thing? And we end up just giving a little bit of reassurance for a lot of the patients that we see. So tongues are fantastically unique. I bet a few of you, at least in the audience, will have a tongue that looks a bit like this. So this is something called geographic tongue, or erythema migrans is its posh term, red patches that move around the tongue. And it's normal. It's the equivalent of me having freckles and someone not having freckles in the audience. It's what makes us unique. A few of you will have a fissured tongue, which is sometimes more delicately termed scrotal tongue. And often these occur together, and we can get quite a florid picture when you do put them together, but we commonly see them together, and it's really normal. You can get bifid tongues. You can get crenulated scalloped tongue. A lot of you will have it with your exams coming up because you clench and grind and you mold the tongue into the shape of the teeth, and it looks like that. This is one of the kind people that I work with who volunteered his tongue-tied tongue for this lecture tonight. And this is the normal stretch of a tongue. But you can see his stretch is going to be really limited by that tongue tie. A lot of these are corrected at birth, but some adults persist with them quite functionally intact, really, and there's no need to do anything about them unless they're concerned about it. We get a lot of referrals for persistent thrush that haven't responded to antifungal treatment, which is unsurprising because it's not thrush. If you can see it properly, it's just a coating on the tongue. If you looked at a tongue under the microscope, it's not smooth. It's got little hairs, hair-like projections called papillae, and everyone's papillae are different lengths. People with longer papillae are much more likely to attract a thicker debris on the tongue, which is just constituents of saliva, foodstuffs, mouth rinses, smoke. And people who accumulate that, especially if they're dehydrated or if they are not eating properly, if they're under the weather and they don't have that natural exfoliation of foodstuffs going over the tongue, then you begin to build up something like this, and it's just a coating. You can give it a scrape with a toothbrush if you want, but it's normal. And it definitely won't respond to antifungals. If you look under your tongue, you have veins there, sometimes really prominent. If they're really bulging, we call them varicosities. And this is, again, a normal thing. Just like veins elsewhere, they can become varicose like this. And sometimes, can you see this okay? Sometimes it can become abnormal. And this is an overgrowth of blood vessels known as an angioma. But again, this lady has lived with this appearance for 50 years and is quite happy. And in fact, taking this out could cause some quite a lot of problems functionally. It wouldn't leave very much tongue tissue, and it would bleed a lot if you tried to cut into this. You can get other lumps and bumps as well, other than on the tongue. So these are really common abnormalities called bony tori, and if you felt one of these, it would feel like a hard stone, because it's just bone. And I had a lady in clinic the other day who had a torus a little bit like this in the roof of her mouth on the palate, and she was adamant that she did not have a swelling in the roof of her mouth, when it was quite obvious that she did, but because that was her palate, she'd never known anything different, there wasn't an unusual swelling in her palate. Whereas if this arose in you or me, we'd think that something was up. Again, they're not problematic. They come on the insides of the bottom jaw, and as well as the midline of the palate. And they're only problematic if you were to make dentures in later life, for example, and you wanted the denture to sit comfortably and really tightly against the gums. I don't know whether you'll be able to see these well, but this is the inside of a cheek, and there are little yellow spots. You might maybe be able to see this a little bit more clearly. Up on the top lip here, we have all of these yellow little spots, just called Fordyce spots. You see them on genital skin as well, and people often get worried that they have warts when they see these. But they're just what we call ectopic sebaceous glands, which means sebum-producing glands that are usually in the skin that are placed in the mouth where they shouldn't really be. They don't do any harm, but they're there. A lot of pathology that we see is simple, benign overgrowths of normal tissue. Polyps are really common, particularly if you chew your lip, or if it's next in a bit of your cheek where you have a broken down tooth, or you're catching your cheeks between your teeth. And these are easily taken off, but we don't need to. They can stay there. They might get a little bit bigger and be irritating, but they can stay if they want. And a lot of people like to have a good suck on their cheeks or on their tongue. It's quite a common habit to do. And if you're constantly rubbing any skin, it will thicken up. And it's like, imagine, sitting in the bath with thick skin. Imagine if you've got thick skin in your hands and feet. It looks white after you've been in the bath for a while. The mouth is one big bath. It's just wet all the time. So if you've got any thick skin, it looks white. And that's what's happening here. The side of the tongue is completely thick and white. And if anyone asks you if you have any tattoos and you say no, then you might want to have a quick look in your mouth and double check, because you might have one of these amalgam tattoos lurking, which is just a little bit of staining from a bit of one of your silver fillings that you have in. And sometimes the filling comes out when you're taking a tooth out, or it could be just pushed into the gum when you're putting the filling in. They're harmless. Well, you can see this very well, but we often see freckles or little moles in the roof of the mouth. And they're usually an isolated lesion, maybe 2 or 3. If we start to see a few freckles that are new, then we put our thinking caps on a little bit. There are certain endocrine or hormonal conditions that can cause excess pigmentation in the skin and the mouth. Addison's disease, for example, you get an increase in a hormone called melanocyte-stimulating hormone, which causes new pigmentation, and it's sometimes quite florid in the mouth. So if you do develop lots of these things, then that's something to go and seek some help about, and you'll have a blood test to see if anything's up. And I think the thing that we worry about with pigmentation is something called a malignant melanoma, which I'm sure all of you will have heard of, but usually on the skin. But it can happen in the mouth as well. And when it does, because I said we don't go poking around in our mouths, it often goes unnoticed. And these things can often have quite a poor prognosis when they're found in the mouth. Now, this is also an early malignant melanoma. And you can see our problem. If we whiz back to the simple freckle, they look really similar. So often we have a low threshold for just taking a little sample of these things just to check that it's nothing worrying. Sticking with skin cancer, a lot of you will have seen people who have little crusty bits, usually, sometimes on the head of bald men who've been out in the sun, where they've lost the protection of their hair. And these are not skin cancers as such, but they certainly have much increased risk of becoming one. And we can get something similar on the lips. It's much more subtle, usually, on the lips. And what we do see is this loss of distinction at this border between the lip and the skin. And I like to be able to imagine that I've got a lip liner and draw it along the bottom of the lip line. But I would struggle a little bit with this. Where is it? Is it down here? Is it it loses its distinction. And you get the crusting at sites like this. I don't know whether you can see it very well. And these are often much more risky lesions than the skin lesions, even though they're a bit more subtle. So don't ignore these, and always wear your sunscreen on your lips as well as your skin. Okay, so let's cut to the chase. The lecture the title promised that we'd talk about stuff like this, so let's get right in and talk about warts. Okay, so the human papillomavirus, that's what warts are. And there's over 100 types of this little virus. And people worry about it for 2 reasons. 1, STD. Is it an STD? And 2, can it turn into a cancer? Michael Douglas has developed oral cancer now because of an HPV-driven process. And we know the link with cervical cancer, but it's becoming much more widely known, the link with oral cancer, penile cancer, anal cancer as well. So like I said, there's over 100 of these little viruses. And what type you are infected with will dictate what lesion you get, how infective it is, and whether it will increase your risk of cancer or not. So the type that we see most commonly are caused by types 6 and 11. And they give these little papillomas, which are simple little cauliflower-like lesions that are often under the tongue or on the palate. There's one a little bit bigger there, but it has this characteristic cauliflowery-like appearance. And they're really not very infective at all, and they don't increase your risk of cancer. We don't classify them as STDs. We chop them off and usually forget about them. Kids who have warts on their hands, verrucas on their feet, carry a different type of HPV, usually types 2 and 4. These are really infectious, and often you see them around the front of the mouth. They're called verruca vulgaris, and they are really infectious, not a risk of cancer, but again, very infectious. We don't classify them as an STD either. Any of these things can be passed on by contact, sexual or non-sexual. And about 80% of you in this audience tonight will have had HPV and probably been none the wiser, because our bodies, with a healthy immune system, we clear it in a couple of years, and we don't all present. When we talk about warts as an STD, we talk about these things, which are called condyloma, or condyloma acuminatum is the proper term. Now, this is genital mucosa, but you'd see it similar in the mouth. And they're big, like raisin-like cauliflowery lesions. Usually seen on the genitals, but if there's any kind of orogenital contact, we see them in the mouth as well. They're caused by a variety of the HPV viruses. And again, like with all of the other things, we usually chop them off and hear no more about them. When we do get worried, is if, I don't know whether you can see this, there's a few there. If there are multiple or persistent papillomas or warts or condyloma, we start to think, why is this person's immune system not capable of clearing this virus? And we think about damage to the immune system, so infections of the immune system like HIV, or malignancies of the immune system like leukemia, even conditions like diabetes, which leave you more prone to infection, we would need to test for. The vaccine, which I'm sure a lot of you have heard about, is against types 16 and 18, which are the nasties of the HPV world. And this is targeted at 12 and 13-year-old girls, ideally before sexual contact, so you haven't had chance to transmit a virus to the cervix. There's an increasing argument for vaccination of boys because of the risk of anal and penile cancer, but because those are relatively rare, it's not recommended at the moment. Herpes, we also see a lot of in the mouth, and there are loads of different types of herpes as well. Chickenpox is herpes, shingles is herpes, infectious mononucleosis is a type of herpes, but the main one that we see in the mouth is herpes type 1, which is herpes simplex, and we'll recognize it as the common cold sore, but it doesn't present initially as a cold sore. Everyone, pretty much, in the audience will have had this. You get it by being in contact with anyone that has had a cold sore. Your parents, other kids when you were growing up, and there's about 100% carriage rate in adults over 30. Again, not everyone presents with it. About 90% of people, when they acquire it, don't know anything about it. 10% get this reaction called an acute hepatic gingivostomatitis, which is a self-limiting thing. It usually only lasts for a week or two, but it's quite debilitating when it's there. And it's usually little kids as well, so they're usually quite unwell with it. And then the virus hides in the nerve. It doesn't go away, it just hides. And it waits for the right opportunity to come back. And it's usually when you're feeling rubbish and don't need another viral infection, if you're stressed, sometimes you're on holiday, sunlight can bring it back. And you can either get a cold sore or you can get something a little bit more serious. And this is a condition called erythema multiforme, which is an immune reaction as a result of an initial, usually herpes infection. And you see this bleeding and crusting of the lips and these classic target lesions on the skin. And this can extend to diseases such as Stevens-Johnson or or toxic epidermal necrolysis. And these are severe immunological reactions that can sometimes be terminal events. And this is the face of someone who has had this, and it could extend over their whole body. And you could see how they'd easily become dehydrated and pick up infections if they have a skin full of this. Another complication of herpes is Bell's palsy. Now, Bell's palsy is when you have usually a herpes infection of the facial nerve, and that's a nerve that supplies the muscles of the face. And it runs through a tiny little canal in the skull. And if it becomes inflamed, it gets swollen, but it can't go anywhere. It swells up, but it gets compressed by its little tunnel. And it's like you going to sleep on your arm funny and waking up and not being able to move it. You know that feeling? Exactly the same thing is happening here. And again, it resolves after a few weeks or months. But it can be really scary, because if you wake up like this, your automatic thought is, oh my God, I've had a stroke. And a bit of a giveaway about the difference is this, the eyebrow and the forehead, because in a stroke, you actually get sparing of these muscles, so people can still lift up their eyebrow. And just, if you didn't know, it's the left side here that's not working. You can see she's trying to raise her eyebrow and trying to smile, but she's just not being able to on the left side. If she'd had a stroke, she might be able to raise up this left eyebrow and wrinkle her forehead a little bit, whereas with a Bell's palsy, you just can't do that. Has anyone heard of this study? So we're moving on to a slightly different infection now. And this is going back to Tuskegee in Alabama in 1930s. And it's when syphilis was rife. And it was the rates of syphilis were going up at an alarming level. And the US government decided to create a research project where they would get people with syphilis and observe them to see what the natural progression of the disease was, to see if they could find a cure. Now, at the time, they didn't have a cure, so they could justify this. So they got 400 farmers, black farmers. They were largely illiterate, poor farmers, didn't know much about the condition. It was sold to them as bad blood, and they were given aspirin and ferrous sulfate, so iron, under the guise of a more robust treatment for this bad blood. And they were brought into the study by them being promised a daily meal, some free food, and also $50 to cover their burial costs. So they were quite tempted by this, and a lot of them joined up. 400 people in total with syphilis and 200 without. And it was all reasonably justifiable until the 40s, when this little thing called penicillin came along and was proven to be an effective and safe treatment, a complete cure for syphilis. And this is when it starts to get a bit dark, because the researchers went out of their way to obstruct these guys from getting the penicillin. They didn't tell them about it. They sent their names to local GPs and told them these patients cannot receive penicillin lest they interfere with some government health study. And it took till 1972 for this to come out, and it was a whistleblower called Peter Buxton, who was a venereal disease investigator who got wind of this. And for years, he tried to get it into the public domain, but it took him till 72 for him to achieve a front-page article in the New York Times. And it caused public outrage, and they pulled the program. And, I mean, during this time, World War II happened. The Nazi human experimentation was going on, and the Nuremberg Code was being established. This clearly was in direct contraindication with the Nuremberg Code, but yet it continued. And 128 of these men died because of syphilis and its complications after penicillin was available. 40 wives were infected, 19 children were born with congenital syphilis, and the resulting survivors were given $9 million to share out between them, and free medical treatment for the rest of their lives. But as you can imagine, there's still quite a lot of mistrust of the US medical establishment in this area of America, amongst this community. As with the Nazi experiments, however, we have learned a lot about syphilis. As one of the researchers quoted, it was horrible to read, he said, "We have no interest in these people until they die," because they just wanted to do the biopsy and see what syphilis did to the body. So what do we know about syphilis? It's an infection by a bacteria called Treponema pallidum. It's a sexually transmitted thing. If you have an open syphilitic lesion, and you have contact with it, you have about a 30% chance of acquiring it. Incidence rates are going up again. There are primary, secondary, and tertiary stages, which I'll talk about briefly in a second. We can diagnose it easily, a quick blood test, and we can treat it extremely easily as well. Primary syphilis is sometimes unnoticed. You get these things called chancres. They often start as little lumps, and it's at the site of sexual contact. So it's usually genital or anal. But again, if there's been oral contact, we get them in the mouth, and at sites of sexual contact as well, so the lips and the tongue. And it starts small, but grows into this big, thick, firm mass with a central ulcer. They're painless, and they go away on their own in about 6 weeks. So a lot of people, especially if it's down below, I mean, you would notice that, but if it's somewhere that you don't really look at that often, it might go unnoticed. About 10 weeks after the this is a little tiny chancre on the tongue, and this is another one on the lip. I always think of them as like little donuts, not very appetizing ones, but that's what they look like to me. So 10 weeks after the primary infection comes the secondary infection. And you might feel just generally a bit rubbish, a bit fluey, a bit achy, a bit feverish. Lymph nodes might be up. But you do get some characteristic things that are specific to syphilis. You get this reddy brown rash on your hands, on your palms and your feet, on the soles of your feet. Sorry about this photo. You get these things called condyloma lata, which are similar to the HPV condyloma, but they're caused by a different organism. And they like moist environments, and they have a tendency to come around the anus like there, often mistaken for hemorrhoids. In the mouth, we see these typical ulcers called mucus patches, and these little snail track ulcers, looks like a snail has just crawled over your mucosa and left its little silver trail. And these are classic secondary syphilis signs. And after that, the virus might just go dormant for a little bit. Sorry, not the virus, the bacteria might go dormant for a little bit. People might not develop tertiary syphilis, and if you do, it might be years after the primary or secondary infection. When it does happen, however, this is when the damage is done. The main issues are damage to the heart and the arteries, neurosyphilis, so reduced cognition, personality changes, hallucinations, delusions, hearing problems, vision problems. You also get these things called gummas, which are these granulomatous tumours that are scattered around the body. And you can see them up here. They look quite like a rubbery, firm lump. And then they can necrose and they can punch out. So you can see this one punching in the middle. And this is looking up at someone's palate into their nose because of the loss of the palatal tissue there where the ulcer's been. And they can be quite disfiguring. So this is kind of just a representation, but of someone who's been disfigured by syphilitic gummas. So something a little bit more boring than syphilis, but it's more common, so it's worth talking about. Oral candida. We all have it. If I swabbed all of your tongues now, we'd get some great strains of candida coming through. And so it's normal to have it. What's not normal is if we are allowed to overgrow it. And that happens if our immune system is weakened. So again, the leukemias, the HIVs, stuff that I was talking about before, even things like diabetes, or local factors in the mouth. If your mouth is really dry, if you're smoking all the time, if you're using a steroid inhaler and not rinsing out afterwards, if you've had antibiotics, these all predispose you to getting this, and it's usually treated very easily. It looks like a cottage cheese, and you can scrape it off to leave a really red, sore red base. And often candida doesn't look white at all, it looks red. And this is a person who's taken their denture out, but it actually looks like they're still wearing their denture because you have this red, irritated mucosa because the fungus infiltrates into the fitting surface of the denture. So whenever you put the denture into the mouth, it just reestablishes the infection. And this is a candidal infection on a tongue. Sometimes if we have it in the palate and the tongue, we call them kissing lesions. Not the most romantic thing in the world, but it's because the tongue is touching the palate and kissing it, supposedly transmitting the infection. Some forms of candida can be a little bit more worrying. This is something we see in smokers. Inside of the corners, inside of the mouths, a plaque that you can't scrape off, unlike thrush. And this is thickening up, and it's called chronic hyperplastic candida. And we get worried about this because it is classified as a pre-malignant condition. We often end up taking samples to make sure it's not becoming a cancer. You can throw antifungals at this, but it will not improve, I can guarantee it, unless you stop smoking, which is sometimes easier said than done. And this is a gentleman. Well, let me start by saying, we're all sitting here now blissfully unaware of how well our immune systems are working. So that bottle that you were drinking from, that's teeming with bacteria and fungi, the food that you're eating just now, just even in the air, all of the bacteria and organisms that are around, we don't know about them because our immune systems work. They do a good job. This guy's immune system didn't work. He had a condition called myelodysplasia where he didn't produce white cells, so the cells of the immune system. He had a tooth taken out, and the extraction socket was colonized by fungus. Normal fungus that we could clear, that we are exposed to as well, but because he couldn't fight it, it was allowed to overgrow, and it infiltrated his maxilla, ate away the jawbone, went down into the lungs, gave him a pneumonia, and he passed away a month after he had his tooth taken out. So that's how dangerous simple fungi can be. And I don't know whether you'll be able to see this well. It's a CT scan looking at the sinuses. This is a normal one, the sinuses and the maxillary bone. And you can see the blackness, which is normal air, normal pneumatized maxillary sinus. Here we've got infiltration of the fungus, soft tissue infiltration, these fungal masses with erosion of the bone. And it's our job as dentists as well to look out for signs of a weakened immune system. HIV is a really common one that presents in the mouth. And because it's an infection itself, it's a viral infection, but it presents with other infections because it weakens your immune system. So commonly, thrush, warts, and gum disease, which is a bacterial infection, put them all together, make them unresponsive to treatment. You have to start thinking about why. And HIV is one of those things that we think about. So, I like talking about gastrointestinal disease. I won't talk about it for very long today. I know the time's ticking on. But if we think the mouth is just an extension of the bowel, we're like one big polo mint. So we start here, and there's a big hole that runs all the way down. It's right to the very bottom. So it makes sense that disease of the bowel can present in the mouth. Sometimes it's the only site that the disease presents. And there's one disease I want to talk to you about because it has such a profound effect on the mouth, and that's Crohn's disease. And I'm not going to lecture you on Crohn's disease. The classic abdominal symptoms are pain, lots of diarrhea, feeling generally unwell, the urge to go. You'll suddenly need to go to the loo to pass stool. Sometimes you'll have an accident, you get fecal incontinence, and this thing called tenesmus, which is when you've gone, but you feel like you haven't finished, you want to go again. You can get bleeding, you can get fissures, you can get lots of perianal stuff, and loads of oral signs, which I'll just show you quickly. So when a bit of bowel doesn't work, it doesn't absorb. It doesn't absorb minerals, it doesn't absorb vitamins, all the nutrients that is usually absorbed, so ferritin, folate, B12, all of these things. And these begin to show in the mouth. And when you are malnutritioned and you're lacking in one of these, your tongue can become shiny and smooth and red and sore, something that we call atrophic glossitis. You begin to get cracks and redness in the corners, angular cheilitis. This is a 16-year-old boy that came into our clinic with oral Crohn's disease. And this is a condition called cheilitis granulomatosa, or a sign called, it's basically swollen lips. And this is, do you remember when you're 16? Any little physical imperfection is a really big deal. And it's really heartbreaking to see these kids, because they do present young, coming in, and they're already really withdrawn, sometimes quite depressed because of this. It's actually a little bit hard to treat as well, so we don't have an overnight cure for it. But imagine going to school looking like this. It's hard work. It would be hard work. So you get these big swollen lips with cracks in them. This is just what's happening. I know this is ulcerative colitis, similar in Crohn's. This redness and inflammation in the bowel extends up into the mouth, and you can see the redness and the cobblestoning, so the swelling that we see in the cheeks. You see tags and these long ulcers that extend all the way down in the crevice between the gum and the cheek. And sometimes you see these odd things. This is pious stomatitis, which is associated with bowel disease, ulcerative colitis, and Crohn's. And Crohn's disease doesn't necessarily present with overt gastrointestinal symptoms. You might see stuff in the mouth, you might not. You might see something called erythema nodosum, which is really tender bruise-like lesions over your shins. You might see inflammation of your eye, and can you see the pus beginning to accumulate in the bottom of the eye there? And you often see these ulcers called pyoderma gangrenosum. These are really nasty-looking ulcers that are often mistaken for malignancy, but they're not malignant. They are just a reflection of some underlying systemic disease like Crohn's disease. Put all of these things together, even without bowel symptoms, and you might start to think about inflammatory bowel disease. And just to finish, I couldn't pass by without talking about oral ulcers. We all get them, well, we don't all get them, but a lot of us get them. There's lots of different types, but when do we need to take an ulcer seriously? These are the type of ulcers that we see quite commonly. These are recurring ulcers. You get them maybe once every month, every 2 months. They're small. They might come in a group of 2 to 4, and then they go away after two or 4 weeks. They're annoying, but they're not dangerous. They can be really annoying if they get big. And if this happened in isolation, I'd be worried about this. This doesn't look like a nice ulcer. But if it comes and goes and is recurrent, then that's much more reassuring. There are skin conditions that can cause mouth ulceration. And all of you guys, I'm sure, will have seen lichen planus on the clinics at some point. It's this classic lacy pattern in the cheek. And sometimes it can become really sore and ulcerated. It can extend to the skin, so you get ridging of your nails, alopecia, and an itchy skin rash. Another skin disease is pemphigoid, which is, you see lots of blistering in the mouth. You can see a little blister there, which is a fluid-filled thing, and that pops and leaves an ulcer. It looks quite nasty when you see it. The main problem about this is sometimes not the ulceration, but it's the scarring that comes with it. Again, not so much of a problem in the mouth, but all of the other sites that get it, so genital skin, eyes, can become really problematic. And can you see a scar just here? And that's the conjunctiva of the eye attaching to the conjunctiva of the eyelid. And what will happen eventually as the inflammation continues, the scarring gets worse, it pulls the lower eyelid in, and you've got eyelashes on your bottom eyelid, and that will irritate. You know what it's like when you get an eyelash in your eye, really irritating, and the eye will try and protect itself by keratinizing, and it will become opaque and white, and you'll go blind, which is irreversible. So that's what I worry about with pemphigoid. Now, single persistent ulcers we take seriously. So by that, I mean an ulcer that's been there for kind of over 2 to 3 weeks. A lot of them are due to simple trauma, and you can see here there's a broken down tooth that matches up quite neatly with where this ulcer is. But we often get worried about them because of the length of time that they're there. But until you get rid of the irritation, the ulcer will stay. But what we will see is a response, a healing of the ulcer if we smooth the tooth. So we've all seen the cigarette packets, and I always kind of, it's horrifying to see. But we know, it's quite unusual in a developed country like the UK to see a cancer present like this. It's much more common to see something like this as a presentation of a cancer, a little ulcer that can't be explained, a persistent white patch that won't go away. And as it's left to progress, it becomes more irregular, more inflamed, more likely to bleed spontaneously or feel a bit numb. And what we're left with, if we leave it enough time, is this quite obvious squamous cell carcinoma of the mouth. It begins to protrude, it becomes what we call exophytic. And here's another one, and I don't know whether you can imagine, if you run your finger over this, it will feel hard, and that's because it's invading into the tissues underneath and fixing to them. Cancer doesn't just need to be a primary cancer. We can get these immunological reactions called paraneoplastic reactions to a cancer anywhere. A lymphoma, a bowel cancer, can trigger off this kind of reaction. And sometimes this can be a terminal event in the cancer. It will usually respond if the cancer is treated successfully, but if the cancer is not treated, sometimes this is impossible to manage. And it's horribly uncomfortable and distressing for the patient. And you can see this is a picture of a tongue that almost has no intact skin. Can you imagine having that? It would be horrible, wouldn't it? I thought that was a bit of a depressing way to end things, so I thought I'd just put two extra slides in, 2 or 3, just to slightly lighten the mood a little bit before we leave tonight. And this, I'm sure a lot of you have seen it. It was one of my favourite programmes last year. And this guy, Dustin, it has to be the best character. And I think it's a lovely thing. He's really put this really rare condition called cleidocranial dysplasia on the map. And it's a genetic condition, really rare, where you get an underdevelopment of the central kind of structures, the maxilla included. And you can kind of see he looks a bit gummy. He looks like he doesn't have any teeth, particularly. And you can convince yourself that the nose was a little bit flattened, the eyes are perhaps a little bit widely set, and his upper jaw is underdeveloped. Now, it's a little bit, what's the word I'm looking for? It's deceiving, really, because they actually have quite a lot of teeth, supernumerary teeth. Too many teeth in a small jaw means that they kind of obstruct each other and they can't get down. So they might look what we call hypodontic, so missing teeth, but actually they're full of teeth inside the bone. And they have this, a classic feature of it is that they don't develop their clavicles or their collarbones, so you can fold them up quite neatly. And I imagine that if you're playing hide and seek as a kid, this would be quite an advantage, really. But these guys live with normal life expectancy, normal intelligence, you know, a full, healthy life, just with these little added extras. And Mike, this is this is another something that the students who nominated me tonight have requested that goes at the end of the lecture. And these guys are going to be let loose on the general population in the upcoming few months. But it's an interesting syndrome called the Marcus-Gunn jaw winking syndrome. And it's 2 nerves that are usually not connected at all that suddenly develop a connection. So let me see if I can play it. Let me see. So we've got this guy. Where is he? Oops. Oh, I'm not sure how I do this. Let's see. Oh, there we go. Right, I think it's going. I've really built it up now. It's going to be quite a letdown. So this guy has it, and he's going to try and move his jaw, and then hopefully we're going to see another bit of his face moving. Eventually. There he goes. So he's off. So it's quite the party trick. So that's us. That's us done. Thank you so much for listening. It's been nice to share a little bit of my weird and wonderful world, and I hope you found it a little bit useful, or if not useful, a bit eye-opening. So thank you very much again.